Bueno, yo soy Marcos Gómez y muchísimas gracias a todos por estar. Estoy colaborando con Roberto en organizar el webinar y los 3 días que tenemos hoy por delante. Así que, bueno, un placer y muchísimas gracias a todos por participar.
Welcome everybody to this Precision Medicine Forum focused on robotic surgery held in Santander. First of all, I would like to thank Dr. Marcos Gómez and Roberto Ballestero for the invitation to present this module of the Personalized and Precision Medicine program of IDIVAL. I want to thank them for the external projection of our trajectory in robotic surgery that this meeting means for the Marqués de Valdecilla University Hospital. It couldn't not be otherwise. The entire health and scientific community of Cantabria share this strategic line, and we are aligned in consolidating it. For us, it is an institutional strategic line. For me, as a digestive surgeon and supporter of robotic surgery, it is an honor to present the Robotic Surgery Forum from my current position as Medical Director of Valdecilla University Hospital. This forum is integrated into a broader program of sessions of personalized and precision medicine, really the medicine of surgery of the future. This module involves world experts in colorectal and urological surgery. They have much to teach us, and you will have the opportunity to learn from them without any doubt. I sincerely thank you for your participation. I am sure that the sessions will be very productive. Well, there is nothing more personal than the bond that is established between the surgeon and his patient. It is almost a blood bond. Each patient has its particularities. Each case is different, personal. And the advantages of robotic surgery, widely known to all of you, allow us today to develop a medicine of total precision that leaves behind and allow us to forget that part, let me say, rude, that accompanied us for years, even while using laparoscopic approach. The surgical robots allow us to do an accurate and precise work, avoiding unnecessary morbidity and adapt to the patient in each case. There is no way back. Robotic surgery is becoming the new gold standard. Well, and now let's talk about Valdecilla. 12 years ago, 2008, our hospital assumed a profound structural change with the closure of the old operating rooms and the opening of a large surgical area that led the change of the large hospitals in our country. The new surgical block incorporated the latest structural and technological advance of the time. At that time, I was the surgical director of the hospital, and in this new motivating and exciting environment, Professor Gómez Freitas and I embarked on a pioneering innovative project with our firm commitment to implant, develop, and enhance robotic surgery in our beloved hospital. Dr. Gutiérrez, head of urology, immediately joined the project. We understood that the advantages of minimally invasive surgery would reach the maximum exponent with the precision of robotic surgery. We acquired 2 Da Vinci robotic systems, one XI, the first from a Spanish public hospital for assistance, and another, an X, for our training center. 10 years later, we consolidated our position with the renewal and technological space expansion. We now have 2 Da Vinci robotic systems for our clinical practice, an X and an XI, and another robotic system for training in collaboration with ABEX and Intuitive Surgical. Today, 12 years later, I think we made a great decision. Now, our hospital has a good critical mass of enthusiastic specialists who firmly believe that robotic surgery is the surgery of the future and also practice it. And our patients enjoy the advantages of robotic surgery. In the last 12 years, we have operated 2,894 patients in our hospital, most of them in general surgery and urology. But in the last years, we have an important number of patients in gynecology, neck and head surgery, and thoracic surgery. Robotic surgery has proven to be excellent for the patient. It's effective, precise, and above all, safe, very safe for the patient. But robotic surgery is also effective, safe, and excellent for surgeons. Robotic surgery improves the quality of life of patients and surgeons. And if it is good for the patient and for the surgeons, it's good for the healthcare systems. But also, if a technique is safe, it is efficient without any doubt. This experience, accumulated over more than a decade, has already allowed us to obtain results and demonstrate the effectiveness of the incorporation of surgical robots into studies of quality of life and health outcomes. This line of research of health outcomes will mark the future of research because it is necessary to know the effects of medical practice in the real environments in which they occur. Finally, I want to invite any surgeon who is passionate about robotic surgery to visit at here. Here you have your home, in Cantabria, in Santander, and in Valdecilla. We like robotic surgery, and we like surgeons who believe in robotic surgery. Thank you very much. Enjoy a lot and learn more.
Well, thank you very much, Roxana. Well, good afternoon and welcome to session 1 that will be about robotic surgery in urology. I'm very happy to be here because today we have a very exciting program. First of all, I would like to introduce myself. My name is Roberto Ballestero, one of the coordinators of this forum, together with Professor Marcos Gomez, and I work as a urologist in the Marqués de Valdecilla University Hospital. My field of work is urological oncologic surgery, with experience in robotic surgery since 2010. I would like to thank Marcos Gomez and the direction of EDVAL for giving me the opportunity to participate in the organization of this event. The main objective of this forum is to explore new areas of research in robotic surgery. For this, today we have an excellent panel of speakers. The program for today is divided in 2 lectures of about 15-30 minutes each. And finally, we will have enough time for discussion and questions about both presentations. The 2 presentations will be exposed one after the other. So if you have any questions, you can type them in the chat, both in Spanish or English. And at the end of the presentations, we will formulate the questions to the speakers.
First, I would like to thank the invitation, and it's a pleasure to collaborate with Roberto and the group of Santander, which we know each other for lots of years, and we've been together in a lot of meetings and so on. So it's nice to see and to share with some good friends. Really, we started in 2005 in Fundación Cocher, so I've been doing robotic surgery now for 17 years, and it's an excellent tool, I can tell you. And when I started doing robotic, I said to my kids, Daddy, it's going to have a better time than you. it's the Da Vinci is better than your PlayStation. And really, I'm having very, very good times all these years and evolving, because urology is technology. If we think about urology 50 years ago, it was everything open surgery, everything, just a few of endoscopic procedures. But right in the last 20 years, 30 years, endourology, percutaneous surgery, laparoscopy, and now robotics. So it's an incredible evolution that has changed completely our specialty. My disclosures is that I have performed open surgery more than X years. I will not tell you how many. Doing robotic surgery for 17 years, and always I try to do my best if I can. So these are my disclosures. So as I said, we start from open surgery, laparoscopic, robotic surgery, and here we are. But Da Vinci already contributed. So some time ago, he designed already something to move some arms and something to help and assist the surgeon. But we don't have, since it's going from the past to the present, I would say these are the Halston 7 principles that still are the same, even if we do laparoscopic, robotic surgery, because sometimes I see people moving the robot to moving laparoscopy, not just following these principles, and these are important. Gentle handling of the tissue, meticulous hemostasis. Quite often I see people with the arms removing all the fat and everything is bleeding everywhere. This is not an anatomical surgery, and it is not a meticulous hemostasis. Preservation of the blood supply, strict aseptic technique, minimum tension of the tissues, accurate tissue apposition, and obliteration of dead spaces. So if we follow all these principles, still this has to be done in open surgery. And of course, it appears the laparoscopy, and it's small incisions, less postoperative pain, cost reduction, and instruments to build in cameras transmitting the internal image to the surgeon, and remote handling. So really the minimal invasive surgery, when it was started, and we started in our center about, I think was the year 2000, really also started to make difference. But then the robot, what's the history of robot? Well, in 1920, Karel Čapek from Czechoslovakia made this Rozum's universal robot. And you know the meaning of robot comes from robota, that means forced labor. So this is the original translation of this. But in 1950 was remote guided innovation, for example, for nuclear remote handling, in order to avoid human contact to nuclear products. And then appears great advantages in microelectronics, in computer, and then we have seen NASA robotic arms, deep robotic, deep sea robotics. So, and also appears the ESOP, the automatic endoscopic system for optimal position, optical positioning. And it was really good, and we had it. And in our center, one of the main promoters of laparoscopy at the beginning, Dr. Rosales, was using it, just talking to the optics. The optic was moving in up, back, and so on, so could be easily and to avoid one assistant. So it was really a nice instrument by that time. And then there was the Da Vinci development and birth. It was 1980. So when we think about Da Vinci, say, well, it's easy, they did it, and that's it. No, they had to really work with Stanford Research Institute, with IBM, with MIT, and develop all the different steps, all the different areas. So, and what finally we get it, well, you know, I mean, top display, greater skill, ergonomic comfort, which is important for the surgeon. We are thinking always about the surgery and the patient. Why not about the surgeon? And better accuracy. And there has been, and you already know, the evolution of the Da Vinci system, standard, S, SI, and then finally the XI. So they have been improving and improving all over these years. And also the evolution to single port, that I hope finally we will have the lecture from Dr. Kaouk working. And this is another way going ahead, and we will see the the real positioning of this technique in our daily practice. But also when we talk about the robot, really, is Da Vinci a robot? I would say no, it's a telemanipulation, because we don't give the instructions to the robot and the robot is doing all the operation. No, we manipulate and then the arms respond to our manipulation. So it's active movement provided by the surgeon and modified and transformed by the robotic surgeon system. So it's really telemanipulation. But still, we have to learn it and we have to have some skills. There is a learning curve, because having a robot does not make you a better surgeon. It facilitates your surgeon, because we know there are very different kind of people, very different kind of surgeons. So having a robot, that means that everything will go fine. You have to know the anatomy and you have to do a good surgery. And for example, this is at the beginning with robotic surgery, they were announcing prostatectomy with no side effects, robotic assisted surgery advantages. Wow, incredible. So I think it was not nice. And what happened, and you see here a paper in 2008, that patients undergoing robotic surgery were more dissatisfied. So they had to look, and these were the people more dissatisfied. Why? Because they were saying no incontinence at all, potency perfectly preserved. And if a patient was just, there was a single drop coming out from his penis, this was a very, very bad result, because he expected full continence. So since at the beginning, some centers were saying, wow, we have the robot, everything was gonna be perfect. And finally the robot had some problems, okay, with the patient. So it's important to express and announce your own results. This is very important. So the surgeon is still the key. Whenever you do open laparoscopic robotic, you have to do a good surgeon. So a bad surgeon will misuse the master-slave instrument. And when we see learning, you see there are bench models, live animals, cadavers, simulators. There are a lot of different aspects that we have to consider. And of course, there are different costs. But I would say to be first doing some simulators and spend several hours there, I think it's the first thing to do in order to get used. So learning is there, and you have to know anatomy and spend lots of hours, because the patient has not to pay your learning curve. And for example, we have in our center, we have the simulators that you can practice in laparoscopy, in endourology, in robotic, and our staff and residents, they practice there, then can spend hours before they go to the patient. And then of course, is needed experience, strategy, and attention to the detail. So if you are good anatomist, you are precise in the dissection, in hemostasis and everything, the patients do really, really well. Because, for example, in urology, when we operate the prostate, is a kind of a bunch of nerves. So we know that there are several nerves over there that we have to preserve. There is a bunch of planes, because if you have someone, what's the interfacial, extrafascial, and to consider all these aspects is important in order to have positive margins and to preserve a sexual function. And finally, continence, the way we dissect the apex is important, either in open lab or robotic. The good thing in robotic is that we see better, we can be very close to the area, we see with several augmentation and do a better dissection. And just to show here a short clip, this was a cystectomy. I do really more prostatectomies than cystectomies, but I've published more in cystectomy. But here you see, for example, the preservation, nerve preservation in cystectomy. Because quite often people say, well, cystectomy means ileal conduit and no more sexual function. And it's not true. We can also do a nerve-sparing cystectomy, and robotic, as you see here, allows to dissect very nicely, to separate the bundles, and then go very nicely and dissect and preserve at higher level the bundles, and then the patient will be potent and will be continent, because if we do a new bladder, this patient can have almost a normal life. And I think this, at least in my experience, I did also kind of nerve sparing with open surgery, with laparoscopy, but with robotic, you see, you can go just underneath at the apex of the prostate, dissect very nicely, separate the bundles, as you see here, without traction. And then finally, you see, and also the good thing in cystectomy, you can go intrafascially, okay, you see, and go quite high and preserve. In this case, I put some hemologs because there were a lot of veins coming laterally, but you can dissect, you see, separate the bundles, no traction. And finally, you see the bundle here, preserved, and then going high in the prostate, you can nicely preserve all this area, and the same in the other side. You see, we can go quite high and also preserve, and then preserve the sphincter. And if we preserve the bundles and the sphincter, then the patients that we do a cystectomy and a neobladder, they are perfectly continent in 1 month. And this is my experience when doing such dissections of the bundles. And you see here we are in the apex of the prostate, and here you have the urethra, and then, so well, here you see the final result. So we have the 2 bundles, the nice urethra, and then you see the patients are continent and you get good results. And this is thanks to the robot. And for example, these were my first cases in radical prostatectomy several years ago, that I had to look at the potency, and really you see that initially it was, oops, sorry, it's not moving. Okay, sorry. And now, you see I had at the very beginning about 93% continence rate at 1 year, meaning no pads at all, no pad at all. And the few ones that had some loose was only 1 pad. So the results are really good. And also related to sexual function. At the beginning, it took some time to recover from sexual function, but once you learn to separate the bundles, not to traction them, the recovery of the sexual function is already at 1 month and 3 months. So it gets better and better. So all this is a learning curve. And also with intercorporeal diversion, and also, for example, here, I'm doing a partial nephrectomy. I also do partials, and you can find what I love in partial is to do enucleation. I've been doing enucleations in open surgery for lots of years, and then in laparoscopic, and then in robotic. You see, you find this nice plane of enucleation, and when you find it, you will see, follow the plane of enucleation, and then when you follow this plane, it comes very nicely with the robot. You see, I already have clamped the artery, and then you see with you assist with the dissection, and then bipolar in this case, and then you can find the plane very nicely. And I don't think it's necessary to cut all the kidney, because then it's more bleeding, more risk of fistula. And you see here, and now going posteriorly, the nice thing also you can do with the robot, you guys, and dissecting posteriorly. I see, but there is always, even the bigger the tumor what is, you can dissect this nice plane and have finally, and I will show you here, you have removed completely the tumor without any problem. So this is what robotic surgery allows. You see, it's a quite nice and clean space anatomically. And then it's just time, you see, now finishing here. Separating from so when you do this plane also, there are less problems in opening the calyx or the fundibulums. You never, almost never, if you separate benignly, almost never you have problems. And then the rhinography, I like also to, for example, this was another case, I like not to do a very deep stitches into the parenchyma because there is more ischemia to the parenchyma, or you can fix a big branch of the artery. So I like to go not too deeply and suture very nicely the kidney, and then they go really well. I've done the last year several cases of partial nephrectomies as well, and the majority of patients have gone home in 2 or 3 days and almost no bleeding, as you see, and then decline. So you see there are a lot of possibilities, and you can really very nicely suture with the robot, which offer an advantage, as you see, in prostatectomy mainly, cystectomy, if you do a nerve sparing in cystectomy as well, and do the intracorporeal diversion with the ileal conduit or neobladder. So all these things facilitates and improve the post-op period to our patients. So small or not so small improvements, but improvement. So what about new robotic system? You see, there are different ones. Avatera got the CE mark in 2019. Single-use instruments and 5mm pores is there, not really established yet. We have the Hinotori in Japan. It's in 2020. It will be in the international market in 2022. As you see, it looks a little bit more like the Da Vinci system. Apparently, it's quite good. We will see. Oops. Then we have the Medtronic Hugo, robot assisted, was licensed in Europe in 2021, has 4 separate robotic arms, an open screen, as you see here, you're not in, you are out, not like in the Da Vinci system. Open screen, the high definition and 4K. It's the same screen used in laparoscopy for stores and 3D, and an ergonomic console. And we recently bought it also, the Foro system, and as you see here, manipulating, here the system working, with excellent systems of the Gaya. So it's a very good solution. I did the first robotic prostatectomy in Spain some weeks ago. And also I did the first robotic cystectomy with an intercorporeal ileal conduit with the Hugo system, and really went very well. So new robots coming. And what value do we expect from the robot? Economy, results and cost, it's important. Safety for the patient, effectivity. We'll have to have a look at the Cochrane reviews of the different areas that we use it and the real usefulness. And then a structure, process, and results with a Redis Donavellian evaluation globally. And the value of the service is defined by who receives it. This is important, and not only who provides it. So this is, we have to take into account the opinion of the patients. And what we expect for the robotic surgery for the future, cost reduction, clearly. I mean, the first robot, the Da Vinci system, we know that there is a cost for its surgery, which is quite high, but it's there, and it's really very good system, no doubt, but the cost is quite high per patient. So when we will see more in the market, probably globally, there will be a reduction of cost. It's the same, if you remember, with when you bought a car, at the beginning, there was no GPS, there was no ABS, there was no radio, there was nothing. And finally now, no one will sell a car with all these things already installed for a similar price right now. So I think the robot will happen the same. So there will be cost reduction, and it's needed in order to evolve. Let's see. And then affordable learning and training, technical improvement, and then, of course, the possibility of neurosurgery. Though that means universalization for the patient. This has to be available in all the hospitals and be used in all the hospitals. But because right now, there are centers that have the robot, but because of the cost, they don't use too much, or they just reduce the how many surgeries will be done per month because of the cost. I think once the cost will be reduced, more patients and more will benefit from it. Oops, I don't know what's happening here. But okay, so the future, haptic feedback is needed. I'm used now to robotics. I can palpate the arches, can do everything because I've done a lot of cases, but to have an haptic feedback is important. The Firefly technology we already have to see the quality of the tissues. Virtual reality, and we are now involved in 2 studies of virtual reality to impose images into the field you are operating in order to see, I don't know, the arteries in partial nephrectomy, to see if you are repairing an external iliac artery for renal transplant, to see where the atheroma is there, if there are areas that you cannot clamp because you cannot palpate very nicely, then to use this technology, and we are already doing it for Fundación, image-guided surgery, telesurgery, micro-robotics, and of course the application of artificial intelligence. And are there autonomous surgery? Well, we see that things are coming, and for example, the Aquabeam platform. This is almost a robotic surgery because you plan the surgery, you pass the button, and it cleans the BPH. So even it's needed to coagulate at the end a little bit, but it's coming. It's autonomous. We are there. Or the Euclidean system for autonomous robotic assisted prostate brachytherapy. So the brachytherapy is planned. You put all the instruments there. You do the cross fusing of the images, and then the system puts all the seats where they have to go. This is already, it's ready in the market. Or they are working, for example, in this automating soft tissue surgery using the STAR system in bowel suture. So there's already, they are working that you put the instrument, put the bowel there, and the suture is done automatically. This is really autonomous surgery. This is robotic surgery, really. But we will see. We are getting there, and we have to get it. And our old friend cited a lot of times, Albert Einstein, let not pretend that things will change if we keep doing the same things. So we have to be there, we have to evolve, we have to adapt and think about the possibilities in order to change. And, sorry, I don't know. Oops.
Okay, thank you very much, Joan. Congratulations for the presentation. It has been a fantastic review of the past, present, and future, especially of multi-port robotic platform.
Hello, everyone, and thank you for the invitation. The topic I was assigned for today is about single port surgery in urology and discussion of potential research in that domain. Let me explain to you a little bit of what is single port and why are we talking about it today. In any innovation, you want to focus on value. Innovations that don't bring value to the patient will not last and will only be a curiosity. And that's why we are gonna determine the outcomes as our main success target. In any innovation, you have several phases that we go through. You have the innovators saying, hey, this is something that will work, while people are still understanding what's going on. Then you have the early adopters who would join and start exploring the new approach. And then you have the early majority, and then you will have the late majority, and then always there will be the laggers who will be the last to join. And every phase is important because it stimulates us to refine our technique, to look and study the outcomes, and to try to improve always on what we are doing. One good way to measure innovations and the phases of innovation was published in the JAMA, and it's called the ideal framework. Many of you are familiar with it, but if you look at the idea phases in the ideal framework, you will see that first comes the first in human. After that, you will do 20, 30 cases, and that is called phase 2A, where you have preliminary studies. And after that, you will have 100 cases or more. Multiple centers are doing the procedure, enough to start making conclusions, and that's phase 2B. And then comes phase 3, where now we have a good viable option where you can compare it to the gold standard treatment, and you start doing randomized control studies. And phase 4, the last phase, is where you have this procedure being commonly performed, and you can then start looking for late outcomes or some of the rare occasions that can be adverse outcomes and so on. In single port, as you will see, we have passed the stage of proof of concept, first in a human, safety and efficacy, and many centers have done now a significant amount of cases that put us at the stage of T2, of a stage 2B, where we are ready to start doing multi-institutional randomized trials. Back to the main topic, single port. Da Vinci robot from Intuitive have passed through multiple upgrades. Usually every 7-8 years, we have an upgrade of the multi-arm robot. But recently, we have a shift from the multi-port to the single port, where one cannula allows for most instruments to come from it into one incision. Even though it's called single port, this is not about one incision versus multiple incisions. It's about an alternative access, as you will see, to try to minimize minimal invasive surgery. The single port robot is a cannula that's about 25 millimeter in diameter and allows for instruments that have two joints, not one. So they are double-wristed for better ergonomics and less clashing, and allows you to perform surgery deep or shallow if you're using the floating duct technique, and I will show you in the movie. Why SP? It's because we can take advantage of this purpose-built robot to go through one incision and stay outside the abdominal cavity. Go to the area where the organ you're operating on. If it's prostate, it's extraperitoneal. If it's kidney, it's retroperitoneal. You can go to narrow areas like transvesical and so on. With small steps that accumulate, that mean one incision, less pain, no narcotic, outpatient, this away from the abdomen, extraperitoneal, all these will accumulate to allow you to send the patient home in few hours, as in our experience. Most important is that when robotics came, it really transformed a lot of the procedures that we used to do open extraperitoneally to the intraperitoneal cavity. But now with the single port, we are able to take back that intra-abdominal surgery to where the organs are in the extraperitoneal space. We have done more than 500 cases since we started, and that is through the entire spectrum of what we do with the multi-port robot, and recently we start focusing on the transvesical approach. This is a diagram to depict the multiple ways to do a radical prostatectomy using the robot. You can do transperitoneal, the standard way, can do extraperitoneal, transvesical, Ritzius, perineal, all these are viable approaches. And recently, since November, we've been routinely offering the transvesical approach for select patients. This is how a multi-port fan-shaped port placement, and if we can do the same good surgery or better through one incision just below the belly button, why not? These are the kind of cases that we really offer single port for. Patients who had hostile abdomen, multiple surgeries, colostomies, J pouches, rectum excised. All these kind of cases make it very difficult, if not risky, to go through the intra-abdominal cavity. For these patients, we stay extraperitoneal using the single port. This is how the robot is ducted through a special bubble port, we call it. The patient is flat, like the open surgery, so no need for a trendy lumbar position. We make an incision just above the pubic bone in the midline, down deep in the fascia to the bladder, open the bladder, put some stay sutures, and then this is the port that goes percutaneously straight from outside the abdomen straight into the bladder. And then the robot is ducted, as you can see there. This is the port. It has multiple elements, and you can put your suction. That's this tube we call ROSI, remotely operated suction irrigation device. It's flexible. I grab it with the robot arm. And here is a small movie that describes what we can do transvesical. So the incision is made. You can see the robot went through into the bladder. We define the trigone. The urethral orifices are seen. And then I start posteriorly. Some of my colleagues start anteriorly. I like to undermine the trigone, define the plane between the prostate and the rectum after getting the vas on each side and the seminal vesicle, and then I will go anteriorly. So I use the scissors in my right hand, a grasper in my left hand, and I can clip for myself with 5mm clip. I have a bipolar to cauterize if I need to, and you can see that the visualization is excellent. And this is the artery to the tip of the seminal vesicle. And now after completely dissecting the posterior plane, I don't go for the vascular pedicle. I go anteriorly, define the plane anterior to the prostate. And after that, I come back and take the vascular pedicle. You can see that the ergonomics is very reasonable since the instruments have double joints. And after getting the vascular pedicle, you can see the nerves, and the nerves are being peeled so that we do nerve sparing. Then the dorsal vein complex is suture ligated to prevent it from bleeding. And after that, we will start excising the prostate by dissecting the apex all the way down to the urethra. And remember that we need to preserve the sphincter and the maximum length of the urethra to maintain continence for the patient. And here the prostate is completely excised, delivered into the bladder, and then we do lymph nodes. So the lymph node dissection is a limited lymph node dissection that we do bilateral from the gap created by excising the prostate. You can see the obturator nerve laterally, and this is a limited lymph node dissection, and that's why we limit our selection criteria to low and moderate risk prostate cancer. For the high risk prostate cancer, we go extra peritoneal, not transvesical. Here I'm using a V-lock suture, and I start by the Rocco stitch, that's the posterior reconstruction, to create a platform behind the bladder and approximate the bladder to the urethra. After that, the urethrovesical anastomosis is completed as shown, also using V-locks, and this completes the anastomosis. The Foley catheter is kept only for 3 days for these patients, and these patients are sent home mostly the same day. Really what struck us more than the outpatient setting, no narcotics, less pain, is really the time to continence. More than half of the patients, when the catheter is removed, they're immediately continent and don't require pads. And this is a significant advantage that we only saw with the Ritzia sparing previously, and we duplicated here in our series using the transvesical approach. Quickly, other approaches include the extraperitoneal approach. As you can see in the diagram, we go above the bladder. We can go perineal in some cases where the bladder is not accessible due to previous surgeries and so on the bladder. We can do same as the gold standard open perineal approach. We go with the robotic perineal approach, as you can see, for patients who have a very hostile abdomen. We also do a benign simple prostatectomy. You can see even very large prostate up to 300, 400 grams filling the bladder. As you can see on the MRI to the left, we can effectively do a robotic transvesical simple prostatectomy. For pyeloplasties, nowadays we make incision that's down like a McBurney or a modified Pfannenstiel incision to access from down up all the way to the pyeloplasty to perform the surgery. We've even done kidney transplant and auto transplant using the single port, as you can see, the vascular anastomosis using Gore-Tex sutures here. 6.0 Gore-Tex is very effective, and the advantage is that we can perform these procedures extra peritoneally in contrast to all the intraperitoneal robotic multi-port transplants. And this graph shows that in our series, we've had excellent outcomes so far with excellent kidney function. So in brief, we focus on value, and our research should be pointing towards evaluating the value of any innovations that we bring. A value that is for the patient by making it less invasive and so on. For the surgeon, by having more options to tailor our approach to the patients, and also ergonomics. And for the health system, where we're pushing to outpatient, where we're decreasing complications and readmissions and so on. So again, back to the ideal phases, and you can see that we are just completing the phase 2B, where we've done big series that we can publish, and now we're getting ready for the randomized control studies and multi-institutional studies to get to the phase 3. And that's where we are today. So the next step really is the multi-institutional collaboration to perform these randomized control studies. And that's why we as a group have started a SPARC, or Single Port Advanced Research Consortium, where we are collaborating in 12 centers to get a large data pool to really study the innovations and see what value, if any, it brings to our patients. With that, I will thank you so much, and thank you for the invitation again.
I think we start with questions to Joan. Please, Josep.
Well, first of all, I would like to give thanks to Dr. Ballestero and also to the rest of the organizers from Hospital Valdecillas for this kind invitation, and congratulate both speakers for both talks. I think that it would be interesting if we can connect with Dr. Kaouk to ask him something about this excellent surgery that he can do, but I still have some questions if it's really bringing big advantages to the patients. We will see on the future, but let's start with Dr. Palou. As you know, he has great experience in robotic surgery. I have to say also that he has been my teacher on that technology or on that type of surgery. So first of all, thank you very much. But I would like to ask him, because sometimes it's difficult to have the robot available. I don't know if all the people who is connected, they have robot in his hospital, or if they are thinking to buy a new robot. So I would like to ask him, in his opinion, that he is also a good expert in laparoscopic surgery, which is the surgery that we should perform always when it's possible, when the robot is available, or if not, to refer to another center. Which of the urological surgeries do you think, Dr. Palou, is in 2022 really necessary to perform it with robotics?
Well, thank you very much for your words. Well, the thing is, if we can think about money, we can think about the patient, and I think we have to think about both. And as I said, if the cost is decreasing, then it's not such a big problem. But still it is, clearly, in Spain, and not all the centers have a robot. So probably I would say the main advantage, I would say, it's first robotic prostatectomy, because the results, and this has been shown in several papers, and also this is our experience. So in robotic prostatectomy, if you do a nice dissection of the bundles and of the urethra, really the continence results are really good. So there are patients that come to me saying, no, I'm in one center, they will do the surgery. I will not tell which way, but they say, wow, the risk of incontinence is very high, and also erectile dysfunction is very high. I say, when I hear these things, so probably then it's a kind of selection, but also probably in the future, and as they are doing in UK, people, or only a few hospitals to be allowed to do prostates, another hospital to do cystectomies. So very specialized centers that they will do a good job, and then this is the best for our patients. So this is a delicate topic, I would say, but this is what's happening also in the Netherlands right now, and in other countries, in northern countries. But I would say, just going to specific what surgery, I would say prostate, and then also I would say complicated, or as I showed several videos of portion nephrectomies. They were like big tumors, and I went very deeply into the kidney. I could suture very nicely. The patient went home in 2 or 3 days and nothing happened. So I think these cases also robotic surgery facilitates. And then I would say cystectomy with intracorporeal diversion is another big option. I mean, we are doing now all these ileal conduits that they hold home in 5 days, 6 days, and they do very well. And so there are areas that really might benefit. For example, a radical nephrectomy can be done very nicely laparoscopically with 3 trocars, 4 trocars, and you don't need precision. You don't need to to be safe with nerves or other stuff, and can be done very nicely. Reconstructive surgery, pyeloplasty, I think very good laparoscopists can do. Of course, with robot, it's much easier. And other surgeries, so we could think a lot about all the different, but this could be my main comments.
Joan, I have a question for you. Do you think that the present scenario of robotic surgery will change with the arrival of new companies and robotic platforms?
Yeah, for sure, for sure. I mean, we have, if you have a look, as I said before, look at the history of the cars or the shockwave lithotripsy. At the beginning, there was only one machine, Siemens, the La Bañera, no? And it was really a huge cost, and only was a private institution in Barcelona, La Caixa, that bought it and put in one center, and they said, wow, this is not available, will not be possible. And in 5, 10, 15 years, 20 years, finally there were shockwave lithotripsy in all the hospitals, or the majority of the hospitals, because new machines appeared and they lowered the price and was more accessible. And I think it's going to be the same. We know the history. It's the same with the cars. You couldn't buy, or it's the same with the phones, the cell phones. At the beginning was a big phone that cost, at that time, I don't know how many pesetas, was really expensive. Only the rich people could have a phone and a mobile phone. And suddenly, 20 years later, everybody has a mobile phone, and the cost is really much lower. So I'm sure it will evolve. How long it's going to take, we will see, but no doubt.
What I would like to ask you, Dr. Palou, also about single port. We know we don't have experience, so single port is not yet available in Spain. So probably in the future we'll have the opportunity to test. But I like it very much from the presentation of Dr. Kaouk at the beginning, that he says that innovations that they are not impact, they don't have any positive impact on the patients, and they will not last, and they will only be or remain only as a curiosity, And then he has showed that many indications of the single pore are to place the trocars or the single trocar in extraperitoneal areas, for extraperitoneal radical prostatectomy, for transvesical prostatectomy, for retroperitoneal partial nephrectomy. So it seems that the single pore, it's ideal for extraperitoneal approaches, but we still know now, for example, with the Da Vinci system that we are performing many of our procedures from an extraperitoneal approach. So do you think, or what do you think is the real advantages of single pore? Do you think it has real advantage for the patient?
Oh, interesting question. I think if I would say, let's choose which robot do I have to buy right now, I would say multi-pore, because allows you to do a lot of things. And in the single pore, you have to be more, as you see, is a learning curve that for every robot, but he's selecting a lot the patients that he's gonna do. But if you want to evolve more and say, well, and you have enough money at your center, say, well, I'm gonna use also single pore to do a transvesical approach. You can do, he hasn't shown it, I don't know, probably he has done it, a transvesical diverticulectomy, a transvesical adenomectomy, he showed, a transvesical radical prostatectomy. I would say without lymphadenectomy, because to do a peaking lymphadenectomy doesn't make too much sense for me. But 40% they did lymphadenectomy in their patients, but not the real one. So I think if we do a lymphadenectomy, we do a lymphadenectomy, not a peaking lymphadenectomy. So, and for example, if you say, I like the idea to put, for example, to do a small fan and steel, and then put the single pore, go and do a pyeloplasty. Why? I mean, if it's a young lady or a young boy that want to have any incisions, you go from a fan and steel, very small fan and steel, you go up there and you do the pyeloplasty, and it's a quite nice reconstructive surgery with no scars or no visible scars. So I think we can talk about different aspects that could be useful, really an advantage related to other.
Yeah, but they were not doing a fan steel for this approach. They were doing a small McBurney.
Yeah, I saw it.
The McBurney is, well, no, for example, for pediatrics, I think it's...
He mentioned that do a fan steel.
Yeah, but for pediatrics, I think it's a big indication, and probably one of the most interesting in my opinion, because sometimes when that I'm also doing with Dr. Abujon some pediatric cases, it's very hard to place a 8mm stroker or 4 8mm stroker in a patient of 2 or 3 years old. So now we are trying to use the umbilicus, also very close to the hip, to try to hit the trocars, but I think it would be very interesting, for example, if it's possible to place the single pore in the umbilicus, it would be nice. But sometimes I think that with the single pore, and the other day that in our course that we organized at Fundación, which were Dr. Patel, he presented a recorded case, and the message that he said that it's possible, as you can see here, I'm doing quite well and very similar what I'm doing with the robot. But for example, Dr. Kaouk during the presentation said, yeah, as you can see, the ergonomy is reasonable and the movements are very similar. So it seems that it's a little bit more difficult to do a case because probably you don't have, at least in this version, enough energy on your arms to do dissection, contra dissection. So it's a little bit more tough, and I want to see the real advantage of the aesthetic results or the pain of these patients. So yeah. I think we need more cases and more.
Yeah. I think it's tricky to know how to move in order not to have interaction with the arms and so on. And when we had that surgery from United States, he said, if you do this, you have problems. If you do that, you have problems. So you have to be careful with these movements. But this is just a matter of practice. But what's the problem of having 4 incisions in the abdomen in a radical prostatectomy in a 65-year-old man? So, and of course, if you do a transvesical, probably it's less aggressive. But how many paralytic ileus we see in radical prostatectomy? No one. How many problems with the abdomen? Well, a little bit. Sometimes there is some small distension of the abdomen the first 12 hours, but nothing else. Probably if you go transvesically in a small prostate, not too big ones, and you can do a radical prostatectomy. But then he didn't show that the final incision probably is like this, 4 or 5 centimeters, in order to remove the specimen. So, and you have an infraumbilical incision, vertical incision there. So I think there are pros and cons, but, and I think if someone paid to me, I would say, yes, let's go. And I would do some cases probably. But I think it's just a matter of refining. If you have only one car, with this car, you go everywhere. Sometimes with some more difficulties. If you go to the mountains and it's very difficult and you have the right car, you may have problems, but you can go. But if you have the right car to go to the mountain, the right car to go to the highway speed, or the right car to put not too many people, more people, then you have several cars you can choose. But if you have to choose one, I would say then it's another story.
I think it's also interesting the message that he said at the beginning of the presentation. No, when new technology arrives, it's important that we need some people to try it and to try to be if it's really useful. So I congratulate him to be so pioneer on that. So Roberto, do you have any question for Dr. Palou?
Well, yes. Well, comment after watching Dr. Kaouk's video and the multiple approach to radical prostatectomy, I really don't know how to do it. So, well, I think the message for residents and young urologists is do the best you can and the best way you know.
Yeah, no, clearly. I mean, this is what I said. Whatever you do, open, laparoscopic or robotic, do it correctly. I mean, cannot be a learning curve from everyone, and several patients to be incontinent or with erectile dysfunction because someone is learning. I think it's important to do correctly. And if you move to a new technique, to have some good simulators, training, proctoring, someone coming to you to assist in the first cases, and then patients will not pay the price of a learning curve. I think this is mandatory, and then a lot of things can be done. So since we're starting with robotic surgery, we started with prostate. Then I did the first cystectomy in Spain. I did the first retroperitoneal lymph node dissection in testis cancer. And so everyone will say, wow, the aorta, the vena cava, you can move very nicely. And then the ureterointestinal stenosis to repair them robotically. So you can, when you have some experience, and then you can move and do more complicated cases, but you have to have good experience in dissection, in anatomy, and then you can proceed. So I think it's really an excellent tool, and the robotic is the future for a lot of the surgeries. If you want not to spend so much money in just doing all the cases robotically, then you select, and this is what we do in our center. If we do radical nephrectomy, we do laparoscopically, or a very easy partial, a small tumor, not too deep into the kidney, you can do very nice laparoscopic surgery, and that's it. And it costs you a few thousands less euros. And some reconstructive surgery also can be done very easily laparoscopically. And I think right now this is an important combination. If you have a lot of money, you can do everything robotically. I mean, you can eat oysters every day, no problem, if you have money.
No, and I think that also what he said, it's very important extraperitoneal approach for many cases. For example, patients with previous abdominal surgery, but extraperitoneal approach can be done very well today with the balloons that we have, and also we can place the trocars of the robot and keeping the distance among them of 8 centimeters. So I think that it's very interesting to remember that we have this possibility to do extraperitoneal approaches. But I think that nowadays, with the robots that we have, with the balloons that we have, with the experience what we have, we can do it most of the times without any problem. We don't have any clutching or conflicts between arms.
Well, the last question for Joan. Well, it seems clear that surgical robots will spread in all types of surgery. But apart from abdominal surgery, in which other surgeries in urology do you think we will see new robots in the next years, apart from Avicenna for ureteroscopy?
Well, yeah, I mean, ureteroscopy is one option, why not? And we see the Avicenna evolving. I mean, if you can drive, instead of being there, manipulating and rotating and having, why not to have a robot, and then you manipulate very easily and you put the instrument and manipulate, but this is telemanipulation. I mean, in percutaneous surgery, robotically, well, I think there will be, and there's already something assistance in order to puncture the kidney and do the dilatation. So why not robotically in the near future? If you put it in there, and then you put the robot that say, go there, and then they put the needle in and do the dilatation. So there are, and BPH, the aqua beam, probably has to be improved, but it's going in this way. And also, well, we have the vasovasostomy that you can do robotically if you want as well. But I think with microscope, you can do very nicely, but with robotic, you can be more precise if it's needed. So there are possibilities, I'm sure, but it has to really show the advantage and then to have a look at the cost clearly.
Okay. Well, unfortunately, Dr. Kaouk can't connect because his flight has been delayed. So we will not be able to enjoy his robotic surgery experience.
Okay.
So, well, I would like to apologize for the technical problems, and we will move to conclusions. Well, to finish, I would like to thank again the speakers and the moderators for their participation in this symposium and the quality of the lectures. And it has been a pity that Dr. Kaouk couldn't connect. Also, I would like to thank the audience that has followed us during these almost 2 hours. It has been a pleasure for me to moderate this session. And well, to conclude, I think we have had a great opportunity to know the current situation of single port robotic surgery in urology. And at the other side, we have attended to a great review of the history of surgical robots in urology. I hope that thanks to all this knowledge, we can open our minds and create new lines of research in this exciting field that is robotic surgery. So thank you very much to everybody. And I say goodbye and end the session.
Okay, thank you very much. A pleasure.
Very much a pleasure. Thanks.